Thank you very much. I am Dr. Dakshesh Patel, head and neck cancer surgeon, and thank you Viraj and Shivam for this opportunity. I guess you said medullary thyroid, right? It was not conveyed to me that it is supposed to be a medullary thyroid carcinoma, but the case is about medullary only, don't worry. So we have Dr. Jagruti, radiation oncologist, right? We have Niket, surgeon, Shivang Shukla, surgeon, Sanjay Gandhi, histopathologist, Dr. Shruti as a medical oncologist, and Dr. Nisarg. Am I right? Nisarg? No. Shivang is there. Oh, okay. So two surgeon, one medical oncologist, one radiation, and one histopathologist. Right. So we don't have a radiologist actually, but I'll narrate the radiology report whenever it is there. So we'll go for the case directly. The patient is a 44-year-old female with a midline neck swelling of around 2 by 2 centimeter for a few weeks and no other complaints. I'll go through the quick examination so that we don't waste time. It is a thyroid swelling, moves with deglutition, not fixed, no voice changes, no difficulty in any swallowing. So what is the next? The patient comes to a surgeon. So Niket, what is the next investigation or the first investigation you would like to do on this patient?
I would like to do an ultrasound of the neck.
Right. So exactly. So any of the thyroid swelling, we usually go for the imaging service, and most of the time it is the ultrasound of the neck. We have other imaging modalities like CT, MR or the PET. When do you want to do CT as a first choice of investigation, not ultrasound, in case of a midline neck swelling which is thyroid?
So if it is fixed to the underlying structures, if there are neck nodes, lateral neck nodes, I would think of doing a CT scan directly.
Exactly. So when we have the symptoms of pressure symptoms like fixity to the cord causing voice change, patient will have difficulty in swallowing, or patient have palpable lateral lymph nodes, or maybe the bigger swelling which you can't get below the swelling, which we classically see in the examination when there is a retrosternal extension. On those cases you don't go for the sonography, but you directly go for the CT scan, and that will be like contrast enhanced or a non-contrast enhanced?
Contrast enhanced.
So there was another like myth which was prevalent a few years back, that you should not get in the contrast enhanced because it will delay the RAI, but that is a myth now. So you should get the contrast enhanced to get the better anatomical delineation of the disease. So in sonography, we don't have a radiologist, but Shivang, do you suggest, do you ask your radiologist to do a reporting in a particular manner, and which is this thyroid, right? So tell us about something about the thyroids. It is very easy.
Yes, so thyroids will actually differentiate the neck thyroid swellings into benign, not suspicious, mildly suspicious, moderately suspicious, and highly suspicious. And whether to go for an FNA or not will depend on the thyroid score and the size.
Yes,
that
exactly.
Is how I go ahead with the case.
So thyroids classification is very pretty much standardized now, and 1, 2, 3, 4 or 5 category, and we all have this in this slide, and according to that and the size of the nodule, we decide whether to go for the FNAC or not. So this was the USG report for that patient, hypoechoic nodule of 13 by 12 millimeter and thyroid 4, and there was another tiny nodule of 7 by 6 millimeter in the same side of the thyroid, which was the right side, which was thyroids 1. So next we will go for the tissue diagnosis, right? And Sanjay, if usually there are FNACs which are non-USG guided or the USG guided. While reporting those FNACs, do you feel, or do you anytime you feel that if this would have been a USG guided or not? So any preference of yours whether you are like a USG guided or not?
I recommended USG guided because without USG guided, possibility that we can go more in cystic lesion and we can miss the solid area. The purpose of USG guided to hit the solid area where we can find the more malignancy.
Exactly. So initial days a pathologist used to do FNAC by themselves. Do you do FNAC still by yourself for the thyroid?
I do not recommend, but still I do, yes.
You do, okay. But you don't, you recommend USG guided, right?
Sure, yeah.
And another question, do you prefer FNAC or, okay, so one more question. FNAC from like 24 gauge needle, 21 gauge needle, 23 gauge needle. So There is also confusion. Sometimes we take FNAC from 24 gauge and the cytopathologist says, oh, there is only blood.
Blood. Because it's a highly vascular organ, so gauge is more smaller, we can get more material. That is the reason why we prefer 21, 22, not 24.
21 and not 24.
Yeah.
Okay. And anytime you prefer true cut biopsy?
True cut biopsy, if you suspect anaplastic carcinoma or lymphoma, otherwise strongly not recommended. Biopsy.
So clinically, if you feel that the swelling is more solid,
or infiltrating, other
hard,
organs, yeah.
So that will, in those cases, true cut might help.
Yeah.
Okay, great. So this is, can you just tell us about this classification system, Bethesda? You always report, I guess, according to the Bethesda. So this is another take-home point for surgeons. If anybody, any pathologist, I guess nobody would do that, but if anybody is reporting without Bethesda, we should ask them and report in a Bethesda category, because we have 1, 2, 3, 4, 5, 6, in which according to that we can have a judgment about the chances of having cancer. If you see in this slide, diagnostic category 1 and 2 are the benign ones, and 6 is the malignant one. 3, 4 and 5 are the one which we really don't want, or that will put us more in a little bit thinking scenario, because whether to do total or hemithyroidectomy, we really cannot take a judgment on that. We have a molecular testing for that, but again, in practice, surgeons, how many of you do the molecular testing for deciding whether to do total or the hemi?
A surgery would cost less than the molecular testing, so I feel very less number of patients are ready for a molecular testing, and lately I don't remember any of the patients.
It's not about cost. If molecular testing will help to reach the diagnosis, your surgery will be changed. So instead of focusing on cost, in practice, I don't know about the molecular testing. I know about molecular testing in category 3, 4, 5 theoretically.
Yes.
But if it is available, I strongly recommend it, particularly in follicular neoplasm, category 4. If it turns out to be follicular endopapillic carcinoma, BRAF mutation, your surgery straight away total thyroidectomy instead of do hemithyroidectomy or whatever lobectomy.
Yes. But then again, Shivang, if hemithyroidectomy is done, like Sanjay said, and it comes as a carcinoma, how difficult would be to go back and do total?
Usually we should do a total thyroidectomy within 2 weeks of hemithyroidectomy.
How difficult? It is
not
it's
very
not difficult. So
because we have already done one side, we have to operate on the non-virgin side.
So in present scenario, we have a difficulty in access to the molecular testing rather than going back and doing the surgery again. This is about the Bethesda system. So this patient, we had a Bethesda category 4 and nodule of less than 2 centimeter on sonography. We did the blood workup, T3, T4, TSH, TG. Shivang, do you do calcitonin or calcium at the first blood investigation when the patient comes and you are preparing for surgery or maybe some routine investigation? Do you do calcium or calcitonin with those panel of blood investigations?
I'll wait for the FNA and then
wait for the FNA.
Yes.
All right. So now we have a Bethesda 4. All blood workup are normal. Sonography wise, the size is around less than 2 centimeter. We'll go for surgery. That is more or less agreeable, right? What would you do, Niket? Hemi or total?
I would go with a hemithyroidectomy.
Agree. So this is not a difficult situation to handle. Most of the time we'll go for the hemithyroidectomy and wait for the final biopsy report. So this has come the final biopsy report as a medullary thyroid carcinoma. Right, tumor size is 1.5 by 1.2 centimeter, restricted to the thyroid only, margins free and no LVI, no PNI. Sanjay, what went wrong?
Actually, if a good stain smears, category 4 will not include medullary carcinoma. Maybe pathologist may be carried out with too much follicular pattern and he has missed the nuclear features. So, because in our classification we not include medullary carcinoma in category 4, it includes usually follicular adenoma carcinoma, follicular variant of papillary carcinoma. So even I have in early days missed one medullary carcinoma and reported follicular adenoma, but if good cytopathologists usually don't miss medullary carcinoma on FNAC smear.
So this is unusual reporting, maybe happening very infrequently, right? So we usually don't see follicular adenoma or category 4 converting into a medullary thyroid carcinoma later on. Patient has come back to you, surgeons, what next?
Calcitonin level would be the first investigation. Calcitonin and CEA, both levels.
So we did not do calcitonin before. After the report, after 5 or 7 days, we did calcitonin, it is less than 2. What next? So these are the questions. Would you go for the other side of thyroid? USG was sufficient initially. Would you do a CT scan now? And would you do completion thyroidectomy? And why?
I would be inclined to do a completion thyroidectomy. A CT scan is not required because the calcitonin level is less than 2.
Right.
So just a completion thyroidectomy and keep the patient on follow-up.
Yes, so since calcitonin is less than 2 and see, ideally we should have done the genetic testing for the medullary thyroid carcinoma, but that was also denied by the patient because of the cost issue, and the chances of bilateral positivity in sporadic cases are less than 10%. So, but again, we don't know whether that was a carrier or not. We also decided for the completion thyroidectomy, and patient was operated for the completion thyroidectomy, and the left lobe, which was removed, came out as a normal thyroid tissue. There was no tumor in that. We all know about the follow-up. We'll not discuss, we'll just mention how would we follow. We usually do the serial calcitonin and CEA for initial 3 months and then 6 months and then yearly. So this patient was operated 5 years back, and we do biochemical as well as the anatomical evaluation. Biochemical is CEA and calcitonin, which was coming less than 2, and CA was coming less than 5 always, and USG neck was normal till now, until patient reported with the presented with the report of calcitonin 14.9 and CA 3.9 in the 5th year of follow-up. So imaging is required as yes, like. So the first imaging we do was the USG neck, which showed around 14 by 9 by 5 millimeter size of remnant thyroid in the thyroid bed, just 15 millimeter below the scar of the previous thyroidectomy. How frequently will you do DOTA scan for this medullary thyroid carcinoma recurrence, rising calcitonin? Do you do frequently, or?
So if you are not able to localize the disease with rising serum calcitonin, DOTA definitely plays a role. And I think since it's now available,
Yes.
DOTA should be done as a means of follow-up as well.
Yes, so actually DOTA may not be required in this case because the calcitonin was not that high also. So, and sonographically it was localized, so we presume that this is the only calcitonin secreting tissue, but nevertheless DOTA scan was done and the finding was confirmed according to the USG. What next? I don't think anybody would like to do watchful waiting. Before surgery, I'll go to the radiation and medical oncologist. Do you feel that your role is there at this moment when there is a recurrence? Not bad recurrence, some thyroid tissue is left behind, but can you help this patient at this point, or would you refer back patient to surgeon?
If surgery is possible, then first surgery. If surgical inoperable, then radiotherapy has role, but not that much because it's radio-resistant biology.
Right. So surgical treatment is advised, right? So we'll go for the excision of the nodule. So these 3 surgical options. What is excision of nodule only? Excision of nodule with CCND? CCND with lateral neck. What is the preferred?
So the guidelines, the ATA guidelines, they give a suggestion regarding the extent of surgery depending upon the levels of serum calcitonin. In this patient, since the levels are less than 20.
Did you see my presentation initially? No, right? Your answers are matching. Okay, go ahead. You can read and tell.
We have discussed this earlier.
Yes.
So since the calcitonin level is less than 20, we can definitely observe the central compartment as well as the lateral neck nodes.
Yes. So here, since calcitonin was 14.9, the plan was not initially to jump and do the CCND, but obviously to look for the nodes if at all visible at that time. So the guideline says that if there is calcitonin level is less than 20, usually no lymph node metastases are there. Between 20 to 50, ipsilateral central and ipsilateral lateral neck nodes would be positive. 50 to 200, you should do contralateral central and the contralateral lateral neck, and more than 500, you should clear the upper mediastinum node as well. And biochemical cure in more than 1000 picogram is usually not possible. Role of prophylactic neck dissection. And so in this case, because since it was less than 20, we did not do that. CEA also helps in deciding the severity of the disease. So surgery was finally done, and the calcitonin level are dropping, and patient is right now symptom free. So in medullary thyroid carcinoma, again radiation oncologist, when do you think you will be able to help the patient? Not in this case, but in general, what are your indications of giving?
When there is a large tumor involving the esophagus, trachea, including surrounding structure, after that, if surgery are inoperable, then and then we give radiotherapy to give some symptomatic benefit.
Do you give radiation therapy after surgery, like in post-operative setting when the big mass of the thyroid tumor has been removed, bilateral positive neck nodes are also removed?
R1 resection.
It is R0. You say for example, the calcitonins are in thousands, but surgeon is pretty much sure that they have removed the tumor comfortably, nicely. Then do you give radiotherapy after that? No. Okay. And medical oncologist, when your role comes?
So if there is residual after surgery, sir, or if it is a metastatic disease, then we can consider giving systemic therapy, but it has very poor response to it. So the agents which can be used are cabozantinib and vandetanib. But so the responses are dismal, the prognosis is poor, and also cabozantinib is not an easy drug to tolerate. So generally, it's a very limited role of systemic therapy in MTC patients.
But I guess you can control the symptoms of raised calcitonin, which are bad GI symptoms. That I guess are very well controllable with chemotherapy drugs, right? Okay, I guess so. This was the first case which we concluded, and take-home messages can be USG may be sufficient many times in nodules less than 2 centimeter. CT scan with contrast is required for better anatomical mapping of the disease when nodule is doubtfully 2 to 4 centimeter, and definitely CT scan is required when there is a more than 4 centimeter nodule with suspicion of malignancy. USG carried FNAC is preferred rather than the blind FNAC. Extent of surgery on medullary thyroid carcinoma is based on the calcitonin and CEA levels. We did not talk about the IUNM and the use of ICG or NIRAV for preserving the recurrent laryngeal nerve and the parathyroid, but that are used as an adjunct in the surgery. Follow up with calcitonin, CEA, and for the anatomical localization, USG and nowadays DOTA scan are helpful. And the recurrent and the refractory cases will need post-operative radiation or palliative radiation and chemotherapy. I guess pretty much agreeable in all those points, right? We'll go for the next case. A 65-year-old male patient with a fairly large swelling in the anterior and the left side of the neck, which was around 10 centimeter on inspection. No difficulty in swallowing, no voice change, both vocal cord mobile, and clinically get below the swelling not possible. So, Nikit, first patient came to you, what will you do?
So, again, since it's not possible to go below the swelling, we would like to do a CT scan and an FNA.
So, CT scan usually neck with thorax because you want to include
the lower extent needs to be.
Yes. And as Sanjay said, TrueCut will be preferable when there is a big, large, hard thyroid mass. FNSC. Okay.
Large tumors also have large vessels, so the chances of hematoma post any of these procedures is also very high. That's, I think, one of the reasons why we keep on avoiding a TrueCut in such patients.
Okay. And one more investigation that we did was thyroglobulin, which was 1727, which may guide us in one direction, like we'll see in next slide. So CT scan was done. It was 11.7 by 6.7 by 5 centimeter mass from thyroid cartilage till the arch of aorta. Fat planes were maintained. There were multiple neck nodes, level 2, 3, 4 and 5B, with largest one measuring 2.3 by 1.8 centimeter. No evidence of IJV thrombosis. CT thorax. Variable size shape nodular lesions are seen in the lobes of the both lung fields, largest measuring 2.2 by 2.7 centimeter and on the right, and the 4.1, 4.3 on the left side, with pre-paratracheal, perivascular, subcarinal, bilateral hilar as well as periesophageal lymph nodes. So then we did the FNSC, but the pathologist said that we need to do IHC. So we did the TrueCut again, and TrueCut was taken from the multiple parts, and this is all like Chinese letters for us, for surgeons at least. We don't know anything. Nirav will tell me, you tell me whether I should operate or not, right? In these cases, that is all we want as a surgeon. But again, so many markers have been done. So confusion was, I'll just summarize this. TrueCut from the left supraclavicular node was poorly differentiated carcinoma. So the IHC were done. So many markers were done, and then pathologist said that this favors a breast primary. Essentially, breast examination, the anterior chest wall in the male patient was normal. Biopsy from the thyroid suggestive of papillary carcinoma, predominantly follicular architecture, and the NSG 161 gene, I don't know what that is, but that was something showing something. So, and the lung biopsy was showing poorly differentiated carcinoma. We could not do IHC because the sample was not adequate for processing further for the IHC. So, anybody can tell, either medical oncologist or the pathologist, what are we dealing with? Either it is a two primaries separate in thyroid and the lung, or the lung primary which has gone to the thyroid primary which has gone to the lung.
The immunoprofile is, both are different. Papillary carcinoma different, and that tumor is also different. Immunoprofile is strongly suggestive of breast primary. Still possibility that, or otherwise there is a highly de-differentiated area in papillary carcinoma that shows differentiation towards the breast carcinoma. That is the rarest possibility in this case.
Right. So we also conclude the same thing, that it may be a thyroid primary and separate in the lung. So when we, as a surgeon, we don't do anything, we give case to medical oncologist. So give some chemotherapy, then we will see. That was not the case. This was decided in the tumor board, and then this was also not sure whether we are going to cure the patient or palliate the patient, right? So till that point, we were not sure about how we are going to manage. But then finally, it was decided to give this case to the medical oncologist, and all those things were given.
So like if I have to choose one, then sir, we might consider going for nab-paclitaxel plus carbo, because that's the safest regimen to go for, and it would work because it is showing it to be poorly differentiated carcinoma. One possibility is like breast primary or lung, so it will work in all of them.
So considering that, the lenvatinib was started because we were thinking that it may be a papillary thyroid carcinoma going into anaplastic thyroid carcinoma. So along with the lenvatinib, nab-paclitaxel and carboplatin was given, but patient did not show any response. So the second line chemo, the third line.
Anthracycline plus platinum based regimen.
So that was given, and then after few cycles, we wanted to analyze the thing. So we did the scan, and it showed, I'll just summarize this, that the thyroid swelling remained as it is, still operable, and the nodes in the supraclavicular and in the lung, paratracheal, perivascular, all those went down in the size. So there was some hope that with this chemo, if that is going on, so we should do something. Now, would you operate, Niket, in this case where there is a...
So I would also like to know the performance status of the patient.
Patient is good, can tolerate major surgery.
Right. So yes, for the thyroid, we will definitely plan on operating with a bilateral neck dissection, and then probably plan radioactive iodine.
Same. Would you operate also in this case at this juncture when patient is given 2 cycles of chemo, good response in the lung, and thyroid is still operable? So away from trachea, esophagus, subclavian, going into the arterial arch of aorta, but operable.
I think I still test the tumor biology, sir, with maybe third line chemotherapy and then assess, because we are not sure whether it is a thyroid primary or not, and if it was, it should have responded with lenvatinib.
But the papillary would papillary thyroid carcinoma will respond with lenvatinib? No. So FNSC, we have a papillary thyroid carcinoma. That was one thing we had. So as Niket said, we tried operating and we could remove the entire swelling. Size was about 11 centimeter, and the histologic type is anaplastic thyroid carcinoma, minor component without extrathyroidal extension, and major component was papillary thyroid carcinoma, infiltrating follicular subtype. And few nodes were dissected in the neck dissection, as Niket said, and some of them were positive, some of them were negative for the papillary thyroid carcinoma. Second last slide. Next. Yes, so I guess I can conclude this. There is no brainer. We'll give for the RAI, but when your role as a medical oncologist and your role as a radiation oncologist will come after RAI, would you give chemo radiation? You give only chemotherapy for the lung lesions which were still there?
So again, systemic therapy would be a poor choice, to be honest, sir. For that matter, I do not know how much even radiation would be contributing, sir. So radioactive iodine is
Yes, so that was transforming into anaplastic, but still major component was papillary. So we hope that RAI should help, and it will be good. So still, we don't have further data, but if the RAI goes to the lung and it concentrates into the lung lesion, that is good for patient. If not, then better you may continue with the...
You can consider giving lenvatinib or sorafenib or any multi-kinase inhibitor.
Right. I guess that is, we all summarized. Thank you very much. Thank you.